Hello, this is Dr. Bernstein with our July 2020 teleseminar in the middle of the COVID epidemic. Before we start with questions, I'm going to go over a few articles that came out in the past month or two that may be of interest. First one was published in the European Journal of Preventive Cardiology by a group from the University of Minnesota. They did a study with a large number of patients for a period of 25 years. They took a diet history every 5 years three times within a 20-year period, and then did CT scans of their bodies after 25 years. And they were looking particularly at abdominal fat and fat around the heart. And they found that the more over the 25-year period, or the 20-year period that they took histories on, the more fat they would have both around their heart and around their abdomen. So this was really correlating obesity with sweet foods, but because obesity is a precursor of diabetes, you could say it was also perhaps a predictor of diabetes, but they didn't report on the diabetes. What's interesting is that, of course, they came to the conclusion that sweet foods were detrimental, but it's interesting that 30 years ago, when I just came out of my medical training, I had a verbal battle with the top nutrition doctor at the University of Minnesota, at the same university, where he was pushing high carbohydrate, pushing high blood sugars, and now these investigators from the same university find just the opposite, supporting my argument. Here's an article from the journal Diabetes Care, current issue. Diabetics in the hospital being treated for COVID-19 were those who were given insulin to lower their blood sugars versus those who are not given insulin to lower their blood sugars. In other words, who maintained elevated blood sugars, were compared as to what toxic factors in their blood were observed. And what they found was that two particular factors diminished when blood sugars were lower. These were D-dimer, which I've mentioned before on my videos and also on my teleseminars, and which I check regularly on new patients that come to see me, and also interleukin-6, which is an indicator of inflammation. So many of my listeners have asked, is it just the diabetes that makes diabetics more likely to die from COVID-19, or is it the high blood sugars that they have while they're infected? And I, in the past, could not answer that. I said it could be either or both. Well, we know that people with poorly controlled diabetes are more susceptible to infections, but now we also know that if you're in the hospital with COVID-19 and have high blood sugars, you're more likely to have elevated levels of D-dimer and interleukin-6. In other words, you're more likely to get inflammation. And it's inflammation of the vasculature that appears to be a major factor in the deaths from COVID-19. There's been lots of talk over the years of a relationship between vitamin D levels and type 2 diabetes. And up to this point, it's been very hard to find if there's really a relationship or even a causation. And this article in the recent issue of Diabetes Care is entitled Untangling the Gordian Knot of Vitamin D Supplementation and Type 2 Diabetes Prevention. And their conclusion is we really need a large-scale study. We can't tell, which is sort of the way it's been all along. Here's an article that addresses the question of lactic acidosis from metformin. Metformin's predecessor, fenformin, many years ago, maybe 40, maybe 50 years ago, actually before I learned to measure my own blood sugars, so it may even have been 60 years ago, alcoholics and people with liver disease were found to develop lactic acidosis if they were taking fenformin. And since that time, there have been arguments by some doctors that because metformin is chemically related to fenformin, that metformin would also cause lactic acidosis. And this was never demonstrated in clinical trials. And here is a more recent file, a more recent study where patients who were taking metformin, people who were taking sulfonylureas for treating their diabetes, and what was the incidence of lactic acidosis in each. And of course, it was very rare in both groups, usually in people with kidney disease or possibly liver disease. And there was no difference between people taking either of these two drugs. And of course, these two drugs are totally unrelated in their modes of action. And I guess they wanted to compare the metformin to another diabetes drug rather than just to a placebo, because they were using existing health records. So again, no evidence that metformin causes lactic acidosis. Here we have a study recently published in an ADA journal, a comparison of U100 Lantus insulin, or glargine insulin, with U300 to see if there's any difference in the efficacy in terms of hemoglobin A1C and blood sugar variation. And what's interesting is that they found no difference. The A1Cs with the U100 versus the U300 were almost exactly the same, but the values of the A1C for the two groups, which were so closely supervised, there were doctors supervising the dosing of both the Lantus insulin and their mealtime insulin. The average A1C was 8.63% for these groups, They were almost identical, and that's an average, and their average fasting blood sugar was 203.6. So here you have a group of doctors treating 463 patients, happy with A1Cs of 8.63, average blood sugar of about 240, and of course the range of A1Cs was very great. It was from 6.9 to 13.1. 13.1 is about an average blood sugar of about 320 milligrams per deciliter. So here, these doctors were happy keeping these patients at very high blood sugars with wide variations in their blood sugars. And when you do that, the fine tuning that you're going to be able to get using U100 instead of U300 insulin is not going to make much difference. When I treat patients, I'm talking about A1Cs hopefully under 5%, with a very narrow range of blood sugars. We're talking children. Maybe the target blood sugar is 75 for the younger ones, maybe even lower for the very young ones, and a range of maybe plus or minus 15 on their blood sugars, not talking about several hundred milligrams per deciliter. So I cannot buy that these two insulins are equivalent. The U300 is going to be much harder to measure. When I have patients taking a fraction of a unit of insulin, you can't measure that with U300. It's hard enough with U100, and that's why we use a diluted insulin whenever we can. Unfortunately, the only insulin that we were able to dilate, long-term insulins we were able to dilate, which were lenti and ultralenti, are no longer available. Okay, this is another one in one of the ADA diabetes journals. It was a very long article, 25 pages long, saying T-cell epitopes and neoepitopes in type 1 diabetes, a comprehensive update and reappraisal. Well, an epitope is an antigen, usually a protein or a piece of a protein, that is attacked by an antibody. And many type 1 diabetic families are familiar with the fact that some endocrinologists will only call you a type 1 diabetic if you're making what are called GAD antibodies or anti-insulin antibodies. And if you're not producing these antibodies, they won't call you type 1 diabetic. And there are many type 1 diabetics that are not being treated because they're not making these antibodies. Well, what this long article shows is that there are already hundreds of known antibodies which are listed on these pages, or I should say known antigens to which antibodies can be made. And many of them, we know what we have seen the antibodies in association with type 1 diabetes. So it's not just two antibodies that are involved. There's possibilities of hundreds. And to rule out type 1 diabetes because you have not found GAD and anti-insulin antibodies is utter nonsense. There's also the fact that a patient could be making the antibodies when their beta cells are being destroyed, and then later on they no longer have the antibodies. So this was really an eye-opener with hundreds of substances that people are making antibodies to. in type 1 diabetes. Here's another one from a recent ADA journal. Integrated pancreatic blood flow, bidirectional multi-circulation between endocrine and exocrine pancreas. I've discussed the proposition that you can take beta cells, multiply them in a lab somehow, and transplant them into humans and expect them to function reversing diabetes. And this is, again, an article reiterating a point I've made over and over. The beta cells in the human pancreas are interacting with other cells in the pancreas, with other endocrine cells. It's called a paracrine effect, where one endocrine cell works on another endocrine cell by giving it hormones. And the blood flow, the blood circulation in the pancreas, in this article, is shown to be between not only different endocrine cells and one another, but between endocrine and exocrine cells. Exocrine cells are the cells that make digestive enzymes. So the environment for human beta cells that make insulin is very complicated and necessitates the proximity of exocrine cells, not just other endocrine cells. So it makes it all the more hard to cure diabetes by just plopping new beta cells somewhere. Even if you plop it in the pancreas, you have to do it where they have the circulation that matches the circulation of existing beta cells. Many of my listeners have asked me if the damage to the brain caused by diabetes is just from long-term elevated blood sugars, or could sudden elevations do damage to the sudden brief elevations do damage to the brain. And I might also say that we've had the from the high blood sugar doctors, many of the endocrinologists, that normal blood sugars are dangerous to the brain. Here's an article, I believe, in the journal Diabetes in June of 2020. Acute hyperglycemia, that's high blood sugars, increases brain anterior cingulate cortex glutamate concentrations in type 1 diabetes. In other words, the chemistry of the brain changes when blood sugars are high. Not just that there's glucose in the brain, but there are other changes, in this case glutamate. And the glutamate, let's see, is associated with cortical thinning and depressive symptoms. Cortical thinning, the cortex is up front near the top. It's where cognitive behavior occurs. And the excess levels of glutamate are associated with thinning of the cortex and symptoms of depression. So again, we have these endocrinologists advocating high blood sugars, and even a brief high blood sugar is associated with excess glutamate levels. Now we're going to go to our questions, and before we read the questions, I want to remind you that my answers are going to be generic answers that don't necessarily apply to the individual who's submitting the question, because I don't have a physical exam, I don't have a complete history, and it's virtually impossible to have a perfect answer for someone whom you really don't know. Advice on promoting healing of blackened toes and bottoms of feet and huge blistering on the feet from when, this is I guess someone talking about his wife, when she did not have circulation. Well, to me, this looks like one of two possibilities. One is a condition called livedo reticularis, which is blood clots that may flow down to the feet, causing spots of dead tissue. But more likely, this is gangrene, which is associated with dead tissue, which doesn't reverse. I think that she should right away be seen by a peripheral vascular disease specialist to see what can be done. To me, it sounds like pretty advanced disease. Could you please give me the name of the lab test that lets you know the size of my LDL cholesterol? Yes, this is LDL particle size. The small dense particles are believed to indicate hazard, and the large buoyant particles are supposed to be benign as far as we can tell. I have an 11-year-old son, which we manage pretty well with food and insulin regimen. His A1C is 4.9 after following your guidelines. My eldest daughter's A1C came back 5.7. I started checking her blood sugar before and after meals, and usually before would be in the 90s and after would be 115 to 130. My question to you is, what would you suggest doing about her high A1C? Well, I'd certainly suggest that she be on a low carbohydrate diet. And one question is, does she have diabetes? Well, the American Diabetes Association would say that her A1C is normal. To me, it's an average blood sugar of 128. And although the ADA would call her perfectly normal, I would call her early diabetes. And I would treat her to get her A1C down under 5. How can we support the honeymoon phase with an optimal insulin regimen? And would it be better with basal or with bolus insulin? Well, an optimum insulin regimen is whatever works to keep the blood sugars normal around the clock. I've found that for some of my newly diagnosed type 1 diabetics, I can get away with very tiny doses of a basal insulin. Sometimes even once a day, might be a half a unit or a quarter of a unit. But you have to check blood sugars and see what happens after meals. And if they're going up after meals, you have to cover the meal, whichever meal is raising their blood sugar. Might be one meal, it might be all meals. And of course, they should be on a low carb diet. And if even with a very low carb diet, and by very low carb, I recommend the 6, 12, and 12, but scaled down for little people. So if you're a child with a weight of 35 pounds, we might have only something like 2, 3, and 3 in terms of carbohydrate grams per meal. If you need diluted insulin to cover a meal, that's part of the ball game. You do everything you can to keep blood sugars normal because high blood sugar is toxic to beta cells, and you want to keep them alive as long as possible. And if possible, for the remainder of the child's life. Should we type 1 diabetics consume a pre-workout meal or snack before we go to the gym? Of course, covered by insulin bolus. Well, if you're properly covering a meal or a snack with an insulin bolus, you're going to have no effect. If you've done it right, it'll be a washout. So why bother to do it? Different people have different plans for how they handle workouts in the gym. Some people find that their blood sugars go up when they do exercise. Some find they go down. Some find that they don't know until they do the exercise. What I find is that mine usually goes up, but a little bit, usually goes down, but a little bit per exercise. So I may walk in, if I'm lucky, with a blood sugar of 83, and after 1 or 2 exercises, I might drop to 79. I'll immediately take enough glucose to get me up to 90, and then hope that I can do a few more exercises before I come down again. And I'll be repeatedly taking small amounts of glucose while I work out. I usually work out for about an hour and a half in the gym. When I do my elliptical training at a high heart rate, again, I check my blood sugar during the workout. I usually have 3 tries where I attempt to get my blood sugar to attempt to get my heart rate to my theoretical maximum. The first try, my theoretical maximum is 156. So my first try, I might be able to get it up to 132. And then I'll rest. I'll check my blood sugar, correct it if it needs correcting. And then on my second try, I'll probably get it to 145. And then on a third try, I usually get to 156. And I may or may not have to take insulin after each of the 3 tries. Not insulin, glucose. Do dietary unsaturated fats cause muscular lipid accumulation and in turn increase insulin resistance? I don't believe so, but I was taught in medical school that dietary carbohydrate is the backbone for fat produced by adipocytes and also in muscle tissue. In flu season, how can diabetic patients better prevent getting the regular cold or flu? Well, first of all, you should avoid exposure. If you can possibly avoid going into movie theaters, airplanes, any enclosed spaces with crowds of people, that should be primary. If you're obliged to do that, you should not only wear a mask, but also take Sambucus, which I've mentioned in many of my videos. So about an hour before you leave for the theater, you take 2 Sambucus lozenges. If I put 10 to 15 grams of olive oil into the meat with more than 5 ounces of meat, my blood sugar will remain at a high level, about 120, and stay there until the next meal. However, butter doesn't have this problem. Is this normal? I don't know why you would put olive oil into your meat. I don't know why you would put butter and add butter to a meal just for the hell of adding butter. I see no purpose to it, to either the olive oil or the butter. And I'm surprised that one will cause a blood sugar increase and the other won't. I just don't know. So there are things that I don't know. Does insomnia often happen to new type 1 patients? It's quite common, usually due to nocturia, that is, having to urinate at night. They usually have high blood sugars, and they repeatedly have to urinate at night. So when I was undiagnosed for 2 months and not getting sleep because I was up all night peeing. Finally, when my parents sent me to the doctor, I was diagnosed. Do you still feel the brand name glucophage is worth the additional cost? I am using the generic and it seems to work. Well, that's fine. There are generics that work for some people and not for other people. There are generics that give adverse effects like diarrhea to some people and not to other people. And from the brand name, which by the way is made by Merck KGaA, capital K, capital G, small a, capital A, in Germany. There's also another Merck that does not make glucophage. The Merck product is available in Canada. It's not very expensive there, but it's not going to be covered by U.S. insurance if you purchase it from Canada. So I think that in theory at least, the Merck brand is the safest, but I have patients, I think of my many patients who take Metformin, only 2 are buying it from Canada and getting the brand name. I am 32 years old and have been Let's restart. I am 32 years old and have had type 1 diabetes for 15 years. I have moments when I begin to have visible edema on the lower and upper limbs, but I have these episodes only when I am very drastic and careful with nutrition and want my blood sugars to be 70 to 100. I would be interested if you have ever encountered such issues, and where can I find an answer? My hemoglobin A1C is 6.5%. Well, 6.5% is an average blood sugar of 160. So it's hard to say that your blood sugars are running between 70 and 100. There are many causes of edema. I could mention a few of them. One would be if your serum protein level is low, such as an immunodeficiency disorder where you have low globulins. Kidney disease can cause edema. Usually, these last two are edema in the legs. a low thyroid can cause non-pitting edema in the arms and legs. And that's about all that I could think of. To tell if your edema is pitting or not, you press the region with a finger, press it deeply, remove the finger, and if the depression in your skin immediately returns, disappears, it's non-pitting. And non-pitting edema is characteristic of low thyroid. Does an infusion of vitamin C raise blood sugar levels in type 1s? If so, is there a solution? Yeah, don't get infusions of vitamin C. Vitamin C is a potentially toxic substance. I don't know why anyone would want an infusion of it. Doses above 4,000 milligrams per day raise blood sugar and can also have been associated with cancer. And much smaller doses of the order of 500 IU in a day can poison the enzyme in the blood sugar test strips so that your blood sugar readings are not accurate. And if you have a continuous glucose monitor, it can also injure the enzyme in the monitor. Does frequent hypoglycemia affect memory? If you have loss of consciousness with convulsions, you do develop microhemorrhages in the brain. Now, I haven't had such an episode since the old days before blood sugar monitoring. Protein has been found in my urine. How dangerous is this to my kidneys? Well, if the protein is albumin, it's a sign of kidney disease that already exists. It's not that the protein is dangerous to the kidneys, is that the kidneys, if injured, can leak protein. And the particular protein that you're interested in is albumin. It's interesting that we did a study a few years ago that found in the general population of people who had submitted a 24-hour urine to LabCorp for testing that many of them, in fact, about 40%, had no microalbumin in their urine, but did have elevated protein. I'm trying to do a study to find out what protein has been found in the urine of these people. It's 40% of supposedly normal population, but we're going to hopefully get more information. So it's the albumin in the urine that we're worried about in diabetics. My son is 6 years old. I take him to the lab and A1C was 8.5, which is an average blood sugar of around 140. Fasting blood sugar 350. So the pediatrician told me it's definitely type 1 diabetes. No lab in our country tests autoantibodies. After 20 days, his need for insulin is declined, and now he needs only 6 units for the whole day. So what is your opinion? My opinion is that he still has beta cells, that he has diabetes, and that you want to preserve the beta cells. Read my book and do everything in there that it says to keep blood sugars normal. You may need to use diluted insulin. You may need fractions of a unit of long-acting insulin like Tresiba. Very important to prevent beta cell burnout. And I might add that this is something that's totally ignored by the ADA and by endocrinologists in general. Dr. Bernstein, are you in nutritional ketosis all the time? Do you ever test your blood ketones? If so, what is your typical blood ketone level? Dr. William Davis suggests being in ketosis all the time. Can that be detrimental to health? This is why I ask. Well, I haven't tested my blood for ketones. On occasion, once a year, I'll do a 24-hour urine, and also they'll do a dipstick on it. And I can't recall there being any ketones in the urine. I'm not seeking to generate ketones in my urine. I've been on 50 years of a low carbohydrate diet, so the low carbohydrate diet hasn't done me any harm, regardless of what Dr. William Davis says. So I can't answer your question. I doubt that I have nutritional ketosis, and if you're on a low carbohydrate diet and getting adequate protein, the only time you might have ketones in your urine would be if you wake up after fasting overnight. You wake up in the morning, you might have some ketones. If you're pregnant, most pregnant women, non-diabetics, when they wake up in the morning, have ketones because they have two creatures on board trying to get nutrition from the fat that was built up during the first trimester. So I'm not going to worry about this. I'm a 23-year-old male and weigh about 150 pounds. I'm just curious as my insulin doses are so low. Currently doing 1.5 units of Tresiba twice a day. Also, I take 1 unit for 20 grams of protein. I get 1 unit of regular for 20 grams of protein and 1 unit for 12 grams of carb. Now, in my experience, on average, people who are of average weight, 1 unit of regular covers 8 grams of carb, and here this guy, it covers 12 grams, and 1 unit for most people covers let's see, 1/2 unit covers an ounce of protein. So 1 unit covers 2 ounces of protein, and 2 ounces would be 12 grams, and this fellow is covering 20 grams. So I'm surprised. I've never seen this, but I guess it's a possibility. Now, it could be that he's still making some insulin, and the insulin he's making is covering the food, partially covering the food. My OB recommends I switch from Tresiba to Levemir because she does not believe Tresiba is safe in pregnancy. My allergist does not think this switch is necessary. I have tried both of these long-acting insulins and prefer the blood sugar effect I have with Tresiba. What are your thoughts on the safety of Tresiba during pregnancy? Well, you could search the internet, as I did. I cannot find any indication that Tresiba is dangerous during pregnancy. And since you claim you're getting better blood sugar control with Tresiba, we know that normal blood sugars are essential during diabetic pregnancies. So if you want to have least damage to the insulin, to the infant, I would say that you need normal blood sugars. Is adult stem cell therapy successful in treating type 1 diabetes? Well, there's no such thing really being done. There's, I believe, a group in Israel that found a substance that can get the beta cell stem cells that are located in the tubules through which pancreatic enzymes are secreted. Those cells are one of the stem cells for beta cells. This company's been around a long time, been claiming that they can convert those cells to beta cells, but I've seen no reports lately, and I doubt that this is being done successfully. Some medications can restore some beta cells, beta cell function as a side effect. Why aren't they tested clinically or even used off-label for this purpose? Well, I know about verapamil. You know about other medications that restore beta cell function. Please let us know, because I'd like to know. I'm being treated as a type 1 diabetic. I am on both long-acting insulin once daily and fast-acting before each meal. My doctor still has me on metformin twice daily and mentioned now that I'm on insulin, I may eventually not need the metformin now that I'm insulin dependent. What are your thoughts on continuing metformin as part of my therapy? I don't know, but if you're insulin resistant, the metformin may help. So one way to find out is to, if your blood sugars are really running level on your regimen, you might want to stop metformin for 2 weeks, see what happens to your blood sugar, keep a record of your blood sugars, see what happens to them if you go 2 weeks off metformin, and if they go up, you probably should restart the metformin. If you're a woman and have blood sugar swings with menstrual cycle, the metformin for some women can minimize that, can reduce the amount of swing. What's your opinion on CGMs? The one I am interested in is the Dexcom 6. I have a Dexcom 5. I find it necessary. I require my type 1 diabetics to use Dexcoms. We now have the Abbott Freestyle Libre 2 coming available in the USA at some time in the near future, we think. It supposedly is going to be less expensive than the Dexcom, so that's another possibility. I certainly recommend continuous glucose monitors for people who take insulin. And the reason for this is that they give a warning if your blood sugar gets too low. I'm a type 1, 66-year-old male, diagnosed about 3.5 years ago. I'm 5'11" and weigh 155 pounds. Thanks to your book, I brought my A1C down to 5.6 from 14.9. 14.9. That's pretty darn high. It must be a blood sugar around 500. My doctor wants me to start taking rosuvastatin to reduce risk of heart attacks and strokes and blocked arteries. My lipid panel came back pretty good, except for a slightly elevated LDL. Kaiser's the insurance plan, and my doctor claim I have a highly elevated risk for a heart attack or stroke because I'm diabetic, and recommended taking it even if my LDL was normal. Well, again, we have a whole group of doctors, because the Kaiser group has their own hospital, their own doctors, and they're just looking at LDL instead of at LDL particle size. This fellow may have high small dense LDL, or may just have high large buoyant LDL, which is not threatening. So I would suggest that they do the right tests. And there are so many other tests that could be done to measure cardiac risks, such as oxidized LDL, lipoprotein small a, C-reactive protein. They could do an imaging study, calcium score, which would be a very good idea. And it would also be nice to get his A1C down a little bit from the 5.6. Now, it's remotely possible that he may have a calcium score of 0. And if that's the case, why give him the statins? The statins do reduce inflammatory markers. So the C-reactive protein might indeed be reduced by a statin. The lipo small a might be reduced. So they might be of value if he has high levels. But it would be worthwhile to do the tests. Have you heard of type 3 diabetes and the link to Alzheimer's? If so, your comments. Well, there's been speculation about elevated blood sugars being associated with various types of dementia. And there's the claim is that type 2 diabetics have 1.6 times the incidence of dementia of as non-diabetics. So if you have diabetes, type 2 diabetes, your relative risk is 1.6. Now, is that a reason to call dementia type 3 diabetes? I don't know. I question it. For the past 4 years, I have suspected that I was losing my ability to make insulin. I had an A1C of 5.7 in 2016, then backed off on carbs, and have been 5.1 or 5.2 since then. I do not have a diagnosis of diabetes. I purchased a new glucometer and discovered I was frequently spiking my glucose into the 150s, 170s, and even 195. However, my recent A1C was still good at 5.1. I have since further reduced my carbs. My question is how to get a doctor or an endocrinologist to notice or care about my low insulin levels and how to preserve my functional islet cells. Many doctors look at my normal A1C and tell me I do not have a problem. My doctor 4 years ago told me to put away my glucometer and stop worrying about it. Well, one thing that you could do to make a hard diagnosis that might make your doctor happy would be to get an oral glucose tolerance test. And if your blood sugar goes up to 140 to 199 after 2 hours, you have impaired glucose tolerance, which should be treatable. And if it goes greater than 200, you have overt diabetes. So this should convince any endocrinologist that you're treatable. Alternately, you could get yourself a kindly family practice doctor and see if you could get him to cooperate in the treatment of your maybe diabetes. But my number one suggestion would be get an oral glucose tolerance test. Well, that's it for our current teleseminar. Our next one will be August 26, 2020. That's a Wednesday, August 26th. Look forward to seeing you then. Thank you.